Hi everyone, welcome to Communicating for Safety. This is Nursing Professional Practice, NURS 5053. So before we begin, what I'd like to do is acknowledge the traditional owners of the land, the Whadjuk Noongar people in which we are learning here today. So my respects to those Indigenous and First Nations people in the audience. So, copyright applies. Okay, so if we think about communicating for safety, this directly relates to the National Safety and Quality Health Service standards, in which we're all responsible for understanding and applying, and how they're then translated at a health service level and at a hospital level, and then how we adopt them in terms of clear communication. So we're going to explore components of effective clinical communication, therapeutic techniques. It's expected that you will use ISABAR throughout the semester in your laboratories, tutorials and simulation, and then when you're in the clinical area you will adopt it formally with patient information. And then you're just going to look at recognizing and overcoming common communication barriers. There are some enablers that we speak about as well, and implementing person-centered or patient-centered communication strategies. So when we think about the components of clinical communication, we look at verbal, words, tones, pace, volume, our non-verbal, also body language, facial expressions and gestures. There's written communication, and that relates to our patient files or the records that are maintained, care plans, any bedside documentation, and those bedside documentations need to be as accurate as everything else is, and discharge plans and a variety of records that we use. Digital records you're probably familiar with already in terms of the electronic health records. We know that at national levels we have our own electronic health record that we have completed every time we see a health service or health practitioner. But there are also some of the records, electronic or digital records, that are actually already used in some of the additional contexts in which we work with. So, for example, residential care it does use a digital format for all of their residential records. Telehealth also uses digital records. So there's a variety of records already out there in both the written, the digital, and the open approaches that we use. All relate to that legal requirement. So irrespective of the type of clinical communication we engage in, we want it to be legally sound. Important from your perspective that we apply active learning, so that is, active listening, so that is full attention, reflection and clarification of content that we apply. So when we're thinking around some communication enablers, we use therapeutic communication techniques. These are the use of open-ended questions. How are you feeling today? Reflection, you seem worried about the surgery. Clarification, so when you say pain, can you describe it for me? Or we can use summary techniques. So you've been experiencing and you will report back what they say. So our active listening techniques give full attention to the person. So that means we face the patient, we maintain eye contact, we show them that we're listening, we might nod, lean forward, we might use some verbal cues, we might provide some feedback. So what I'm hearing is approach, and we're going to always defer judgment. So we're going to avoid interrupting or arguing, and we want to respond appropriately, ask questions, summarize, clarify. Okay, so communication barriers, this is really important to avoid these ones. And so these are some of this is not complete by any means, but just things you need to think about. So, false reassurances, don't worry, everything will be fine. No. Giving advice, if I were you, I would, changing the subject, minimising feelings, and sometimes our feelings are minimised by everyone feels that way every so often, is actually derogatory. Using medical jargon without explanation, so you're appearing to be more important than the patient, and you might use leading questions. You don't have pain, do you? And so that could be interpreted in lots of different ways as well. So common communication barriers that we have to take account of are physical barriers, human vision impairments, pain or discomfort, medication effects, because these are the things that might impact judgment outcomes in terms of communication outcomes. Psychological barriers can include anxiety, fear or depression, so mood will influence an outcome. Cognitive impairments certainly, because being a poor historian, they're not going to be able to tell us the type of information that is contemporary, and so therefore we might engage with the carers or the third parties in relation to cognitive impairments. And then also considering if someone's had a previous negative experience, that's always going to impact the type of response. Environmental barriers, very important to consider, noise, lack of privacy, because people are not going to open up if there is a lack of privacy, and if there are interruptions or time constraints as well. So being mindful about some of the common communication barriers are really important. There's also cultural considerations, so we have language differences, personal space differences, eye contact norms, touch boundaries, decision-making styles and health beliefs. So all of these cultural elements are, and because we live and work in a culturally diverse society, we have to be aware of not only First Nations and Aboriginal cultural styles, but we have to be mindful of other cultural diversity approaches. So that's why when we're working in the context that we do, we use our standardised processes and protocols to ensure that we don't offend and we get the best information forward as possible. In terms of health literacy assessments, we use a universal approach, and that is assume all patients may have some difficulty understanding healthcare, and so therefore we approach in a certain way. We use plain language where possible, we avoid medical jargon, and you can see that, for example, the NSQHS actually engages with consumers in terms of directing or including that each health service, when they're developing written information for their consumers, that it actually it meets that consumer engagement process. So each health service, each hospital has consumer engagement that they include as part of their best practice standards, and ensuring health information is actually reflected at an appropriate level. And then visual aids and demonstrations. Other things you need to think about are red flags for low health literacy requirements, and this is why we use our consumer engagement service, but also bear in mind that we might have age-specific communication that we need to be aware of as well. So when dealing with children, when dealing with geriatrics, when dealing with parents, we're always thinking around the age-specific requirements that we need to be mindful of. Communicating for safety, this is the sense that it comes out from the Australian Commission for Quality and Safety, and we have the particular standard standard for communicating for safety. And so here, when we're looking at communicating for safety with patients, carers, families, the multidisciplinary team and clinicians, and it deals with across health services as well. So when we're thinking around effective communication, we're thinking to improve patient satisfaction with care, that we've actually delivered person-centred care and that it's been appropriate and understood and all of those things, that we get treatment adherence and we get clinical outcomes and team communication agreements. So when we're looking at effective communication, we're looking from a person who is involved in that care episode right through to the team approach, right through to ward processes. So, you know, if people need to be transferred from one setting to another setting, we still need to meet that same standard. We apply correct identification and procedure matching processes. This happens at clinical handover, as well as admission to hospital, as well as in outpatients where we don't, we will vary that identification and procedure matching process because inpatient care might be slightly different to outpatient care, but you're going to learn about inpatient care. And then the specific processes for clinical handover, and when we have to communicate critical information that is urgent and not in the standardised timeframes of shift handover, for example, then we need to assure that process as well, and we need to ensure that our documentation of information is also clearly evidenced and legally compliant. So this is an example from the NSQHS around our communication for safety standards, and it aligns with, so even though we have a clinical governance standard, we also know that communication for safety standard also has its own requirements, and we can see that this standard is about ensuring effective clinical communication. So what I would like you to do is actually go and have a look at standards communicating for safety standard from the NSQHS. That is then translated at the health service level and then at the hospital level. And so you can see here, this is an example of how the East Metro Health Service has adopted this standard for all of its health sites. And so you can see that this clinical handover policy scope applies at Royal Perth as well as Bentley. For South Metro Health Service, you would have a similar policy scope, and it would apply to Fiona Stanley, Fremantle Hospital, Rockingham Kwinana Hospital and Peel Hospital, because each health service has its core group of hospitals that align with it. So when we're thinking around communicating well in the clinical area, we're looking to see that our clinical communication is clear and concise, it's timely and appropriate, it's complete of critical information, there are verification and confirmation processes, there are documentation standards that we adhere to, we consider the non-verbal and the active listening techniques that were talked about earlier on, we consider the barriers to communication in healthcare situations, so that is the environment, noise, interruptions, physical layout, psychological barriers around stress, fatigue as well, or cognitive overload, and professional barriers that might relate to specialised terminology or hierarchy, system barriers that impact care team approaches or shift changes, and personal barriers that we might carry around assumptions, biases, and any cultural differences. So when we're thinking around professional communication, we're also thinking around our communication style and their impact on patient safety. So that's why we will always use an assertive approach, such as ISA-BAR, so that we're working within that protocol of communication. And this then negates the passive versus the aggressive communication. We also use ISA-BAR because it's a direct communication method rather than an indirect, because we don't want to be second guessing processes around communication. And we know that communication styles actually influence team approaches and that team dynamics, and so understanding that team engagement and who might be leading the team at that point in time is important, but knowing that team dynamics also change. So having a standard approach of communicating becomes really important. And then of course adapting that communication style to situational urgency or to telephone urgency becomes important. And also when we're looking at cultural influences, when we are working with the translation service, for example, is that we are using that ISA-BAR process as well. Okay, so ISA-BAR is standard. If you haven't understood that, in your Blackboard site there is the WA Health standardised approach that you will be learning. There, each of the hospitals, private and public, will apply that ISA-BAR approach. The privates might tweak it a little bit, but the principle remains the same. So there might be slight variation in adoption, but for learning purposes, what we're looking for is that you will use that as a learning process so that you are clear on the WA Health agenda. We use closed loop communication, and that's what that ISA-BAR is, and it has definition and processes, and the safety of communication standard that has been adopted by the NSQHS is originally based from the aviation industry, because to promote safety, we needed to be very clear around our safety parameters. There are step-by-step guides in Blackboard in our weekly learning that you are going to be working with. And there are critical moments when you're going to be using closed-loop communication. So the read-back, check-back protocols, these are really useful in terms of when we're doing patient instruction or we're not sure if we've actually been clear in our process, and we use that check-back process in our read-back process and check-back protocol in our ISA-BAR as well. So that's just to assure that we're actually being very clear on what is required. There are documentation requirements, and sometimes it's also a really good way to actually communicate information by telephone to someone when you're escalating a concern, or when you're escalating patient concerns to the clinical coordinator. You're still using that ISA-BAR process, and can use it in clinical documentation as well. And so the common pitfalls around not being confident with it, and so using it every week in your laboratory and then simulation will develop your confidence so that you can start to pick out the critical information of escalation that's required. Okay, so we use clinical handover at particular times. So always when there's handover and patient transfers. Now this might be the structured handover at shift change, at bedside change, at telephone, when we are escalating care, when we are transferring a patient from ward to ward, or from ward to residential setting, or from ward to discharge, or from ambulance to paramedic service to ED, for example. So those cross-facility transfers, we use the same approach, and so by having the same approach means that we are all clear on process. We don't have to second-guess protocols. We know the approaches to use, and we're confident with the type of information that is required. Interdisciplinary teams also use that communication styles when there are rounds, when there are medical rounds that are actually attended to by the team. So role clarity, huddles, it's about flattening that hierarchical approach that has been historically used, and ensuring safe communication. We always include the patient in our approach, because standard number 2, which is consumer standard for practice, says we are providing care with and for this person. So therefore, if we are providing care for and with this person, then they need to be part of the communication. And also knowing that there are respectful ways in which we can query information or challenge information. So, we all work to improve and work together collaboratively. Health literacy is a requirement that we think about, and teaching back method is a good way to gauge people's understandings. Family presence, doing rounds and discussions, because sometimes people, if they're designated next of kin, the person in the bed might be anxious about or might not take in all the required information, and then disclosure of adverse events and supporting patients as active participants in their own care. We know that some of the challenges in healthcare result from historically around hierarchy of approaches, so that was the power dynamics, and so that's why now it's very much a team focus, working within that team framework, creating cultures of safety, promoting speaking up culture across all levels, time constraints and interruptions, and so that's why when the escalation of care or when the transfer of care is required, making sure that we actually ensure that we're using ISABAR as that framework helps reduce that interruption and that unnecessary time wasting, and be time efficient. Cultural and language barriers, so that is, we need to work effectively with the interpreter service, knowing that some cultural groups will defer to the medical profession because they believe that is how it should be done. And so that's why when we're working in partnership, we're raising understanding around processes and making sure that we get the right information from people. And then language differences amongst healthcare professionals as well. So this is why for us as healthcare professionals, we need to ensure that our speaking levels are always at the required safety level, and tools for cross-communication and ensuring diversity needs. In semesters 2, 3 and 4, you're going to learn about managing conflict and difficult conversations, so you're going to learn about de-escalation techniques, structured approaches to giving feedback. You'll learn about giving feedback to each other in assessments and working together clinically, but you will escalate that in relation to patient care in semesters 2, 3 and 4, crucial conversations 2, 3 and 4, managing managing your own emotional responses and others' emotional responses during difficult situations is a particular skill, and when and how to include mediators or leaders, leaders, your clinical leaders in conversations are again things that you will unpack in semesters 2, 3 and 4. So we use a variety of technology and communication. So electronic, we will cover some of these things more in detail when we do our written documentation, but just bear in mind that whether you're using a digital tool or a handwritten tool, our legal framework actually applies. And so we always want to make sure that the information that is documented in records, whether that's handwritten or an electronic health record, it has a legal implication. So always best to know exactly what you're documenting. Telehealth communication is that this is a virtual healthcare space, and you will be exposed to more virtual healthcare spaces as virtual care actually develops much more in when you are registered nurses as well. So that virtual space is confidential as well, and you have to treat as though it were that person in front of you as well, and be mindful around when you are using telehealth services what the documentation requirement is. We use secure tools for team communication, and at this point in time you will your tool, you need to make sure that the tools that you use are secure, but when you are registered, you will be part of that digital tool that teams use, and then that has a professional engagement and responsibility for you to consider further down the track. But we're always guided by policies that govern the use of digital communication tools, and so at a personal level, for example, you're mindful about the social media platforms that you're using, and thinking about what might happen if there's an over-reliance on technology, or if our technology backup processes are not so good, what happens then? So that's more around some of the ethical and legal requirements further down the track. Communication errors and patient safety. We know that communication, our verbal communication, impacts a number of patient safety factors, and that's why there's a great focus on human errors, understanding human errors, and minimizing communication errors. So this is why we have such a strong focus of our laboratory learning, our simulation practice, and clinical practice, so that we're reducing errors. So laboratory learning and simulation is a way for you to engage at very different levels and understandings of working within a safety framework. So there are common errors in communication relate to medication safety, surgical safety, delayed diagnosis because of communication failures. There may be failure to rescue situations, so not escalating information in a critical time frame to your clinical coordinator, for example, or to the doctor, or there might be care coordination breakdowns that occur. There's also near-miss reporting and communication, so when there is an actual error or an adverse event, that is actually recorded on the hospital incident reporting system, and all of those, both near misses and actual near misses, are reported and communicated and discussed at a very senior level. So where errors are actually collated and discussed, at the local level, at the national level, and then changes in practice as a consequence, where gap analysis is started to be understood a bit more. And then we have that just culture and speaking up for safety culture. Just culture is the principles of justice. So when you learn around your legal and ethical principles, that it's an ethical principle of justice where equity of care is provided. So it's just care, it's justice care. That is, everyone is eligible or should be receiving that care. Accountability versus blame in communication. So being able to speak up, encouraging error reporting because we want to be able to resolve issues, not pretend they don't occur. And then there's a leadership role in promoting speaking up culture. And the NSQHS has a variety of tools that are available for raising concerns, just as each hospital and health service has processes for raising concerns as well. Psychological safety in healthcare is really important because if people don't feel safe, they won't speak up. And so what we do is work effectively in our teams to build psychological safety within our teams. We're going to measure that impact. We're going to look at error reporting and team performance and their strategies that leaders will adopt to enhance team adoption. So that will be for you something to consider when you're 3, 4, 5, 6 years out as registered nurses. So the key takeaways are: make sure your critical principles for safe clinical communication are applied. Adopt the immediate implementation of safety, individual responsibilities within team communication, and if you don't understand what is required or what's going on, it's important to raise that within that team communication, and that team will come back to you. Raising concerns around patient well-being or patient responses to whoever is in charge of the team for that day. So if you're at a public health ward, like at Fiona Stanley or at Royal Perth, then it's important to know who the clinical coordinator is, and so that you can escalate care to them if your patient is not responding in the right way or has had a sudden deterioration. So system level approaches for sustained improvement are applied at that much more senior level. What you're learning this semester is around safe communication adoption in tutorials, in simulation, in laboratories, and absolutely in clinical practice. So you're going to practice, get better in tutes, sims and labs, and then in the clinical area you should be very aware of the standard processes and be able to work effectively and intuitively within that required ISABAR framework. Okay, thanks everyone.